You started?
Excellent. All right, just a few more minutes before we start. Let's see. It's a new thing, so we're testing, making sure everything works. Can you see that? Excellent. Good.
Chicos, es ahora. ¿Qué es ahora?
We're just periodically muting participants. It's a little bit hard if you're not used to the Zoom thing to know that if you're not muted, then things can get interesting. So forgive us if we mute you, but if you need to speak, of course, you can unmute yourself. I hope everybody can hear me, yes?
Yes.
Okay, great, thank you.
Yes.
Thank you, thank you. Welcome, everyone. Thanks so much. We have Eitan also here that we need to, I'm not sure if I can see the chat. Forgive me if any of the questions are not, you know, if I don't catch them. But okay. Listen, thank you everybody for coming. I've thought, you know, how to begin and what to say. Dr. Nelson is here. So we, you know, obviously it's a difficult time, and perhaps maybe not a good time to start something, but you know, in many ways we've always known that, you know, our field is part of a much larger picture. Thank God most of the people that live on Earth don't need us. Most of the time they maybe need us once or twice or hopefully never. but when they need us, they really do, oftentimes. And so in times like these, you know, we certainly help out with what we can with the infection that's going on, but at the same time, we have a duty to keep going and to keep our field alive and keep the services that we're offering alive, because amongst the stories that you hear, I'm sure those of you that have been involved in this, and, you know, hopefully it'll stop here and not get any worse, just a hope. But amongst the stories that are here, there are also stories of collateral damage and people that can't get the services that they need for other things. And so we're here, we're working, you know, our service is very much alive. And so we need to keep that going, and we need to keep the education strong as well. So basically this is about that. This is just about online education while this is going on, and then we'll see what happens. Hopefully as things transition back to what the world used to be, we'll see if we keep this going or not. But for the time being, we'll do some online education. Some disclosures. This is our core team. We're particularly want to give a shout out to Kitty Pong from Kanagawa, Japan, who is here, who has joined us, and he's going to be showing some participating in this, and he's an amazing part of this whole arrangement. It couldn't have really come together without him and without the others that are on this page. We just want to, you know, what can we say? We acknowledge everybody who is, you know, who is in this fight right now with the virus. Everyone who is part of it. We wish everybody a speedy recovery. A little bit on the etiquette of Zoom. Just if you're new to Zoom, please take a moment to read this. Take a look. You know, there's ways to ask questions. I see there's a lot in the chat already. We'll have Eitan looking at the chat. If there's any questions that you want to ask, you can ask either the group or you can ask Dr. Raz or myself directly. Probably Dr. Raz better at this point. And so without further ado, wanted to start with the veins, I guess, just because it's particularly topic that we enjoy and probably doesn't get as much coverage as the arteries do. And it's always a question, like in my mind, where do you start the veins? Do you start in the sinuses? Like which part? How do you go about it? We're not going to cover too much embryology at this point because I think it's venous embryology. We can maybe do that a little bit later on. But it's just important to appreciate that veins are very much like rivers. The river is only as big as the sum total of all the streams that have joined it. And so in that perspective, if you want to look at the veins, you better look at the little rivers first before you get to the big ones. You understand the little ones, you get an appreciation of what feeds the big one and what you have to do sometimes if the big one is not working. So, I'm sure a lot of you know this, but conceptually, like when we approach the superficial venous system, we like to think of the rule of fours, or just like look at four things. So basically there are more or less four main pathways in which things can go. Over the convexity, you have something that's going to the top, to the superior sagittal sinus. That'll be like a Rolando, Rolandic, Trollard, as I'm sure you know. Going back towards the sigmoid sinus, there will be something like a Labé, right? Going in the Sylvian fissure anteriorly, there's going to be some kind of superficial Sylvian system. And of course, there's tons of variations on the theme. And then last but not least, at the base, we have the basal vein. Now, there's always the debate about the basal vein. Is that going to be part of the deep system? Is that part of the superficial system? I think there are many ways to think about it. And so without getting too much into the embryology, I think there may be disagreement on this, but for me, at least functionally, the basal vein is much more of a superficial vein than it is a deep vein. It's in balance with the superficial system, particularly with the superficial Sylvian system. And it forms late in embryology, which is also different from the internal cerebral system or the deep system, which is different. So we'll consider the basal vein here as well. So this is just another one of these variations. It's just a basic picture, right? There's a lateral view, venous phase. You have an interconnected system. That's another thing that we pay attention to. Kind of like always thinking, how are the veins connected from a surgical perspective, particularly say somebody has an aneurysm here, you have to divide the superficial sylvian vein. Is there going to be a problem or not? Well, probably there won't be. Why? Because there's a good connection to the, what's likely the trillard and then the labase. So somebody else who doesn't have these connections might run into problems from that perspective. So this is a very balanced kind of arrangement, both dominant veins. And then you have here also another variation. If there's one variation here, it's the variation in the basal vein. I hope you can see my pointer. Can you see the pointer? You see the mouth? So you see how the middle segment, so there are 3 segments of the basal vein. The middle segment is a little bit hypoplastic, at least from this injection. Then you see the anterior segment of the basal vein, which is essentially the deep venous, the deep sylvian system that's draining up here towards the cavernous sinus, and then you see the posterior segment of the basal vein draining towards the galen. Okay, and then there's a little occipital sinus here to boot. Huh? Then there's another, so there's, you can talk about this forever. There's all these variations. So here's cavernous region that's draining probably through the ovale, and that's coming into the pterygopalatine venous plexus over here. So there's a lot of things that you can kind of see in any one picture. A lot of what we do has to do with, we use a lot of stereo stuff. We have a lot of stereo on the website, so we won't talk about that too much, but the pictures that have these eyes here are stereos. And so if you know, we didn't like really pre-advertise this, but we're recording it, and so you'll have it online. When if you have one of these anaglyph glasses that you get pretty much, you know, they're anywhere you get a pair of like red cyan anaglyphs. And you can look through those. There'll be a depth to these pictures. And so some of these are going to be, that I'm showing are anaglyphs right here. So, you know, again, when we look at the veins, mostly like what you want to have is a gestalt view of what the entire convexity is like. And for every piece of the convexity, you want to have a vein that drains it, right? So there's variations on the theme as usual. So here's a big, probably a trillard, right? So if somebody has a big trillard, well, there'll be correspondingly small veins somewhere else. So there's a big trillard, that means that, you know, the labae is usually small like here. And so the labae is smaller, that means that the basal vein, which you see here expressed in its full length, the basal vein, which is draining towards the galen, is a little bit larger, corresponding to the relative hypoplasia of the labae. And so like everything is kind of like this. This is the same patient, just the other side. Here, same idea, big superficial sylvian system. So smaller veins going up towards the superior sagittal sinus and so forth. And again, so here's the basal vein, deep sylvian veins draining this way towards the cavernous sinus, right? Even more so, right? There's a whole other interesting part of like what happens here with the so-called sphenoparietal sinus and how that's organized, which is basically like this dural portion of the vein. And that receives, as I'm sure you know, when the sylvian system is large, oftentimes there's multiple veins that are kind of running in parallel. And at some point in time, they'll either join or they won't join each other. So here, ultimately, they do join each other into this kind of like a lateral cavernous sinus type arrangement. But, you know, over here, which is very well like along the sphenoid ridge, there's still 2 or 3 of them together, right? And so here's the drainage. So this is probably, again, this is probably either a valley or spinosum, probably a valley draining into the sphenoparietal sinus, and that's inferior petrosal sinus. More of the same, we'll skip that. So here's just another form of dominance. So just important to kind of recognize all of these things. Big labae, right? So that is seen fairly often. You see a dominant labae system. That we can appreciate also in non-invasive imaging. Right here, we have an MR. You can see if this is, so this is the right side. So here would be a dominant, going back. So if you look on the left, as we go down, more often the labae is more dominant on the left. Who knows why? Some people think it's because of languages on the left, but nobody really knows, I think, why. So here's that same dominant labae in this person on MR. right? Other things to keep in mind, occasionally these are more like surgical pearls. You know, you see sometimes this big anterior frontal vein, anything goes, right? Veins are very variable. Something to pay attention to, particularly like very occasionally there'll be surgical approaches that require the sacrifice or at least the planned, you know, entry into the anterior third of the superior sagittal sinus. And so you certainly want to pay attention to like a big vein like that, because if something like that is in existence, then maybe the sinus, this piece of the sinus is more necessary than it usually might be, right? Something that, you know, there's a whole surgical aspect to this that, that we should keep in mind. The other piece, okay, so there's other variations. There are many ways that there's a whole relationship of how the cortical veins reach the dura, the whole like sort of like bridging vein aspect of it. And here, so this is something that we see actually more frequently than we probably realize, is a dural channel. There's a dural channel that exists right here. So you have a big, not even a labia exactly, but there's a big vein here. And ultimately it's going to join, not the sigmoid sinus, this is a transverse sinus over here, right? So as it does that, it goes through this channel. You see how flattened this appearance is? It has this sort of larger look in the frontal view than perhaps in the lateral view. And there is a wash, there's a paucity of contrast opacification here. So that piece is actually a dural piece, right? So the vein, the cortical vein is here, and then it's connected to the dura at this point. And then this is the piece that drains as a piece of supratentorial dura into the sinus. So you really want to appreciate that. Again, it's more often than meets the eye. And so you really do want to pay attention to that, particularly again for surgical implications. If somebody has if there's a surgical, and it's not so common that we do surgical approaches here, but in this area, if there's a situation like this, the surgeon should be aware of the fact that this vein would actually have a big dural component if they're going to traverse the dura at this point, right? Again, that a lot of this can be seen on MR. We'll have like show a little bit more in a second, but if you look at this is the same patient. You look at this is not even, it's not a modern, particularly modern MRI. This MRI is a very average kind of older MR scanner. You see the morphology of the vein here, and you see how it starts to be like, there's a little inflection point. And then you see this, you can see the mouse, you see that flattened look, right? You see that look, and you see how it extends a little bit beyond the surface of the surface of the brain. So that's really in the dural covers, right? And you can follow that down to where the sinus is going to be. So anyway, just another variation. We'll skip that. Now I wanted to show this again. This is a basal vein. This is a particularly big basal vein right here. And that's another variant. So there's a variant. So that's a connection that the basal vein normally maintains with the galenic system, right? Now here's a variation. I'm sure many of you know this kind of like lateral mesencephalic connection that the basal vein typically makes with the superior petrosal sinus, right? You can see that in the frontal view as well. Now, if you look at the MR of this patient, and so here in the upper left, you see that's the basal vein, right? The full kind of like extent of the vein going around midbrain. Now, when it comes into this point, when you see the drainage, you realize that it's actually not going into the superior petrosal sinus. This is actually another one of these dural channels. So it's a tentorial, it's a dural tentorial sinus. A tentorial sinus is a well-recognized entity, so this is actually in a tentorium. And that's the contrast MR of the same person, okay? All right, here I'm gonna switch, and I just want to end, or before we turn over to Kitty Pong, I want to show a little bit of just to run through a case on PACS. I don't know if we can see if we can switch now. Yep. Does everybody see the PACS images, right? How much time do we have? Okay, excellent. So I just want to show a case. These are all anonymized cases, of course. You can see that one of the advantages of this whole Zoom thing is that you can really like have a window into a real-time evaluation of a particular anatomy. Just set that up. So this is a patient that comes in for a okay. So here's a patient that comes in for an unrelated reason. She has a vertebral aneurysm. But, you know, this is just a normal venous anatomy, right-sided view, venous phase right here. So this is a dominant kind of vein going up towards the superior sagittal sinus, superficial sylvian system. Here's a DVA. Kitty Pong is going to talk much more about the DVAs and their relationship to the whole venous apparatus. And so the DVA has its own draining vein that's going into the superficial system. Now, all of this can be, the message here is that obviously we spend a lot of time on angiography, but if you really want to study the veins, the easiest way and the best way to study the veins is to correlate angiography with MR. MR is, you know, there's a lot of these like sort of volumetric T1 post-contrast sequences, contrast MRVs that are extremely helpful. Perhaps one might say even more helpful than angiographic images and understanding the relationship of the veins to the brain. And so if you look through this picture, you could really see, so we're on the right side and we're gonna correlate the right side to what we see here. So if we go back to let's go to the frontal view. And in the frontal view, maybe let me close that. So here's a frontal and lateral view of the same injection. Again, kind of a dominant Burlandic vein, as it turns out. Up here, there's a superficial sylvian system. There's that DVA that you see in the frontal view. In the cavernous region, you see this kind of like drainage, this variant drainage that doesn't really involve the cavernous sinus. It goes around, and then here we have a kind of a paracavernous sinus drainage into the pterygopalatine venous plexus. We don't really appreciate that's a little bit cut off down below. And then here up where the Burlandic vein is, you see this again, like up usually near the convexity here. There is often a piece of the vein, there's a segment of the vein that doesn't directly drain into the sagittal sinus. It goes through a piece of the dura. So these venous lakes, quote unquote, are these kinds of like variants, or not so variants, probably variation is more like the rule here, is the connection of this vein into the superior sagittal sinus through this dural segment here. And so we're gonna see the same thing. You can basically how we correlate that with, MRV. If we start from below, you see this is a vein. This is that sort of paracavernous sinus vein that comes here. And that's connected to the superficial sylvian system. That's the DVA. That's the vein that's this vein here, right here, that drains the DVA over here. That's the superficial sylvian vein, this part here. And that's going to be connected up here, coming up this way. Now you don't have to guess if this is, you know, Burlandic, if this is Trillard, because you know where the central sulcus is in this picture. And here's that connection to the sagittal sinus. Can I use the laser? Yes, you can use the laser. Okay, there you go. Can you see? All right, thank you. Okay, so basically so we're going back, and then here, We go to the left side. So here's that aneurysm we were interrogating. That's the left side. So on the left, you see a much bigger basal vein, right? And so if you go back down, but there's also like a sizable Rolandic, so that's right here. And if we go down the Rolandic pathway, down, down, down. Now there's no connection here. You see how it just sort of peters out because it's not really connected to the base so much. The base, it's a little bit independent, but here we pick up the basal vein. So this is the middle cerebral vein or the deep sylvian vein. There's the basal vein going around the mesencephalon, and that's coming into the galen. All right. Okay. All right. I might have to. 1 second. Okay. I'm going to mute everybody again. Sorry, you can unmute yourself if you have a question. But if someone's by accident not muted, then we do that. Yes, there's a question. Ah, okay. How to differentiate the Rolandic from the Trilard? I think it's guesswork if you look at the angiogram. You know, it's always a question like where exactly that is. But on the MR, you don't have to guess. This is, where the Rolandic sulcus is where the Rolandic vein is. But I think on the angiogram, it can be a little bit tricky. Finally, I want to show this. 1 second. Oh yes, this can be one. So, I mean, technically the Trilard is a parietal vein, so the Trilard will, go over the parietal lobe, and the Rolandic, by definition, is in the Rolandic sulcus. But figuring out where exactly they are on angio can be tricky. I wanted to show something else, like finally, just to finish. This is again the same patient. Now this is obviously MR goes forward. This is probably the front line of what MRI can achieve. And this is vessel wall imaging. So vessel wall imaging can be ridiculously powerful. And this is the same patient. Again, this is like a sagittal view. So now you see it's a post-contrast T1 weighted image, black blood imaging, and you see, now you see the veins, just yet another way to look at it. Just perhaps not more information necessarily, but just it's a beautiful set of images, and hopefully more and more will have the capability to do this. It takes a while to get these images generated, but they can be very, very useful. We originally got this because we wanted to look at the enhancement of this aneurysm wall, which is its own set of, it's a whole other can of worms, but it does generate these really wonderful venous images. So you can see right here, you could follow all these veins. Look at this. Now you have so here's the superficial sylvian veins. That's the DVA. So probably slow flow enough and thin-walled enough that you obviously don't see the walls, but you see you're going to see at some point, you're going to see this vein. So that's the caput medusa, right? And that's the vein that ultimately takes the DVA territory into the sylvian fissure. You could follow that. These are arteries now here over, I don't know if you could pick that up. You see these two veins here, same as here. Now, if you go down, you're gonna down, you're gonna see, there it is. You see that lateral cavernous sinus. That's like coming down here, and that's gonna drain into the ovale and into the spinosum in this particular case, right? Okay, there's a question. Jay, you have a question? You can unmute yourself. Anyone, if you have a question, you can unmute yourself. I had some, they say probably the pointer is not as good, right? We go back to the mouse. Okay, back to the mouse we go. All right, so let me see if I can, oh yeah, that works, right? I can't see myself now. Here we go. You can see that this is a little bit cut off, but I don't know if you can appreciate this little flattened segment of the vein right before the sagittal sinus. Okay, so questions. Let me see if I can go like this. You can unmute yourself. I don't think you, let me stop the share of the screen. Okay. Kitty Pong, can you hear?
Yeah, I can hear you. Yeah.
Thank you. Thank you so much. So we're gonna turn over to Kitty Pong from Kanagawa. Again, is an incredible partner, and we thank you so much for all your time. Of course, as you know, this is all free. We're not, this is a purely educational activity. But as you can imagine, it's a lot of time. So we really thank you. And we turn over to you for the second portion. Let me just, if there needs any chats. Okay, if there's any questions, we're just starting this, so I'm sorry if you have a question and we're not seeing it, or if we can't get to it, try to use the chat. We'll get to it towards the end. Thank you. So let me, Kitty Pong, I'm gonna give you the host. Right, you got it.
Okay. Yeah, I got it. Okay. Hello, everyone. Good morning, good evening, good afternoon to everyone. I can see that there are over like 200 people joining. That's a very good start. Congratulations, Max. Yeah, Maxim started out this idea of doing something like positive in this time of we have all the trouble all over the world. In Japan, we're quite fine right now. Actually, we have increasing number of patients of COVID-19, but we're still working. We still do elective cases, actually. Okay, anyway, as a supplement to what Maxim has just shown you, I would like to go to share my screen. Okay, what's this one? Oh, that's all. It's the finish. I have to go back. So this is the first one. Okay. Can you see my screen? Okay. Okay. So BANANAZ. There we go. So I'm going to show you some a few cases concerning the superficial venous system. It's going to be on like a more practical side than what the basic things that Maxim has just shown you. I tried. Okay, so if you have a case like this, okay, there's some bleeding over here. Probably I'm going to talk to myself, but I'm going to ask questions. You can chat, you can speak out, anything, okay? So if you have a case like this, an old man came in with a seizure, anything you would suggest for...
I'm sorry. I'm sorry to interrupt. We don't see the next screen. We see the front BANANAZ, superficial venous.
Oh, really?
But we don't see any.
Okay.
We don't see images.
Okay. You only see banana. I'm trying to work this out. Now, what do you see?
Still the BANANAZ.
Still banana. Okay.
Could you be sharing? Do you have a presentation and the PowerPoint open?
Yeah, yeah.
You might be sharing the other one, not the presentation one.
Okay, so this is... Is it working? No?
Not yet.
Try it again.
Try to unshare your, okay, yes, yes, you got it.
Can I see it? Okay.
Yes, yes, we got it.
So you see this case, CT. Okay, so we have a case like this, and you see the circle, the blue circle. No? Yes? Okay. So any idea what it is? Maybe it's too easy for y'all. Okay, so we see there's some blood over here, so there must be a bleed over there. Can be many things. But so this is non-enhanced CT, okay? So let's look at this area. Oh, I cannot advance. Okay, so here it is. Okay, so we see some hyperdense area in the superior sagittal sinus. So now you see the clot, okay? So it's like a clot or thrombosis. So this is when we have a clot in the suprasagittal sinus. Usually, sometimes we see this hyperdense area on the CT, plain CT, the first scan you might do to most patients that come into your ER, okay? And if you do a CT with contrast, you'll see something like they call it the delta sign, which you see the enhancement of the surrounding of the dura mater with the absence of the contrast inside the superior sagittal sinus itself. Okay, so we go again. So the same thing on the same CT, contrast enhanced CT, you see a lot of thrombosis inside the superior sagittal sinus. But the patient had very small, only small bleed in his right parietal area. Why is that? Because we see a lot of other venous system. The venous system inside of the brain, actually, they don't have valves. They don't have valves like in other parts of the body. That's why we get reflux when we have the dural shunt. That's why sometimes we get away with some thrombosis in the sinuses. So as Max was saying, there's a lot of variations. Another important part of the venous system is that we have, when the superficial ones are blocked, there's some other, like from the, maybe this is Rolandic or Trolal, I'm not sure. There are like anastomotic system between the superficial venous system. If you got a clot or something, thrombosis over here, it either drains through the labii or through the superficial middle cerebral vein to the cavernous sinus, or other system like the basal vein of Rosenthal. Okay, so there are systems that are interconnected to help with the drainage of this thing. And also we go deeper, a little bit deeper. Max was saying, is the basal vein of Rosenthal superficial or deep, or a deep vein? It can be considered as a deep vein because it also drains the deep white matter in some part of it, but in some part of it, it's more of superficial vein, rather located deep in at the base of the brain. So this is another important connection from the deep venous system to the superficial venous system, and also a link to the cavernous sinus, and also a supratentorial and infratentorial connection. So when we speak about this superficial venous system, I've put basal vein of Rosenthal over here in the venous system, but actually my personal belief is maybe it fits better down here. Okay, so we've talked about we've seen the variations of the veins draining into the superior sagittal sinus, the variation of labii draining into the transverse sinus. Sometimes they enter the dura earlier than many people will actually imagine. Okay, so these are important points that you have to know to understand some of the cases you see clinically. Okay? So here's another case. A 71-year-old man, he came with some headaches, and we see some blood, some subarachnoid blood in his right, almost the sylvian fissure, a little bit above that, okay? It's not that serious, but actually, so I wasn't there at the time. So the people they went straight to the angio to look for some aneurysms. Okay, of course they didn't see anything. There was no aneurysms, and they said they said there's nothing. Okay, so I got back to work and just looked at the angio, and it looks a little bit like strange on this venous phase. Okay, so we're talking about the superficial venous system, so you might have already guessed what this is. Okay, so lateral view of the same injection, the right IC injection. Go on, go on, go on. Okay, so I think this is the end. Okay, I have to go back. Okay, so it looks like we don't have a drainage into the cavernous sinus, but this is maybe only a variation. But we don't see a big labbe. Okay, we see multiple, whatever you call it, Rolandic. It's just the drainage to the superior sagittal sinus placed quite evenly in this case, but I'm not really comfortable with this. Like you see like a little bit of contrast, stagnant a little bit over there, over the area of the superficial middle cerebral vein. So we diagnosed this one as the cortical venous thrombosis of the SMCV. Okay, so let's compare to the opposite side of the same patient. Okay, so this is it looks more clear here. You see the veins very sharply delineated with this SMCV. Of course, we don't need to have both SMCV draining on same patients. There can be variations, as Maxim said. But this one looks a little bit like it's not really normal. Okay, so we've done other studies on this patient. So this is on the lateral side to prove that it was really a cortical vein thrombosis. So the treatment should be heparin for this, even though the patient has some bleeding on the CT. Another case, a little bit more severe. I'm sorry, I didn't change this in Japanese. A young lady with this like edematous, some bleeding, intraparenchymal, and also some subarachnoid bleed. Okay, so it's like another variation of the last case I've just shown you. So what is this? People were saying it might be a tumor, a bleed from a glioma, another infarct with some hemorrhage inside. So I just took the patient to, we did, the next thing we did actually, we did the MR. Actually, the MRI shows you a lot of the veins and also the occluded veins. You can see the veins with contrast in it, and you can also appreciate the occluded veins that is not filled with contrast. This is very important when you want to make the diagnosis on this kind of cases, because well, we have repeated this so many times that there are variations. It doesn't. So this is the cortical venous thrombosis. It started out at the labbe, extending to the SMCV, and later on, actually, at this point of time, we still have the transverse sinus intact. But later on, even though we gave the patient heparin, she developed more and more of thrombosis at the left transverse and sigmoid sinus later on. So this is, we actually, it was quite difficult to convince the team that this is a venous thrombosis case, and they should give the patient heparin, not the opposite, okay? So anyway, so we took the patient to the angio to make it more convincing to the people. To see, so we see the early venous phase and the late venous phase. So we don't see, again, the labia. Maybe, again, it's a variation, but we don't see a lot of veins over here around the temporal area, okay? So at the area of the bleed, we only see the, you can tell what this is. This is the basal vein of the Central trying to drain as a, like, give some collateral drainage for this occluded SMCV and the vein of Labbe. Okay, so in this case, it is actually more important to for you to make the diagnosis by the MRI. So this is like the contrast enhanced MRI. You can see the clot has grown over time, extending into the sigmoid sinus in the jugular vein and part of the transverse sinus on the left side up to this junction here, okay? But we need to do the decompressive craniotomy for this patient. But she recovered quite well at follow-up. This is at 6 months follow-up. We just wanted to see how the vein has adapted. So we see the recanalization of the labia here. So this is the SMCV draining into the cavernous sinus. So they have all recanalized the veins that have been occluded here. So we see what it used to be and when it was occluded. So this is the result of the cortical vein thrombosis. Okay, so variations. Okay, say similar slice.
Sorry.
Yes. Yeah.
Sorry, there was a question earlier asked in the chat about the first case. The case.
Okay.
The question was like, how to differentiate that from, like, say, there's a dural fistula that's congesting the cavernous sinus or something like that in the veins. Like,
okay. Maybe I go to the next case is probably going to answer that question. Okay. If it doesn't, the guy may ask again. Okay, so this is variations again. Labbe, SMCV, maybe there's quite distributed like equally. This one is like that. This one's like this. This is more equally balanced drainage. This is like what do you call this? Trolla Rodandic. I don't know what it named this. A lot of a bunch of drainage into the suprasagittal sinus. So variations is the rule in, there's no rule in the venous pattern, okay? So these make it difficult for you to diagnose cortical venous thrombosis on the DSA alone, okay? It might not be there, it might not be there. So the MR, to stress again. Okay, so another case, 74, came in with a very bad condition. So this guy, again, we see the absence of the contrast filling of the over here of the superficial sagittal sinus. So again, sinus thrombosis. I was called. We have a sinus thrombosis patient who came in with a seizure, and they sent me the picture. They said, I don't think it's a sinus thrombosis. It is sinus thrombosis, but it's probably not only that. Because why? Because we see all the dilated veins all over the brain, okay? So this must be something that not very acute, rather chronic. It might be chronic sinus thrombosis, but chronic sinus thrombosis, usually they don't cause symptoms. The venous system of the patient will compensate with the occlusion and would have already solved the problems by alternating to other routes for exit from the of the veins from the brain. So I think there's something wrong other than the occluded sinus. So we did angio, okay? So this is probably a way to answer the previous question. So this is like, you see dilated veins all over the area. This should raise the possibility of having a shunt. Usually, if you have a high degree of venous congestion, it's more like dural shunt than we have a like pile shunt type of thing. So this is the external carotid artery injection. So we see some shunt into the transverse sinus, refluxing. So this is the same injection, a little bit later phase. So we see all the cortical veins refluxing. So this, we can see that the SMCV, the superficial middle cerebral vein over here, it doesn't drain properly into the cavernous sinus. So there may be some secondary occlusion there too to make the brain suffer even more. So there comes the question, why, how does the brain drain in this kind of situation? So this is very important when you analyze a case of dural shunt, something like this. So we go to the internal carotid injection. So we see some stagnation of the vein, okay, but we see slightly of something of the straight sinus. We see something over here. I don't know if it's a cavernous sinus. It shouldn't be, because we didn't see a very good drainage from the cavernous sinus. We see something at the superior sagittal sinus. We don't see a lot at the back. So it must be trying to drain somewhere else. Sometimes it's very difficult to see where it's draining because it takes a very long time for the blood, for the contrast to go out, okay? So when there is restriction of the superficial venous system drainage, so what are the other alternatives for the brain to drain? So it can drain into the deep venous system through maybe the basal vein of Sinus, through maybe a transmedullary vein, or you can call it cerebral vein. I will show that in some other pictures. And there are other options also, like it can drain through the veins inside the bone. We call that the diploic vein. It's not very easy to see, but you can see on this side, it's draining through the bone out into the cavernous sinus of the opposite side of the same patient. This is after we have treated a shunt. The brain, this was already occluded a long time ago. We didn't get it open, but the brain is compensating very well using the hemisphere veins and also the diploic vein draining inside the skull. The same thing shown on 3D. It's not very easy to see, but if you think these are like the superficial middle cerebral veins, actually they're not. They are draining inside the skull. This one. You see it move? Okay, it's move because movie might be not very good for if you have low speed connection. Okay, so these are not the SMCV. These are rather the vein inside the bone, the diploic veins. They might look similar to the SMCV. Okay, so there's another route for the brain to drain. There's a shunt in this case at the focal tensoral junction, and there's some drainage. Oops, sorry. Need to try to stop this. Okay, so you can see this vein draining from the subepidermal vein going to the surface to join into the superficial venous system. So this is what we call the cerebral vein, okay? So you usually see in the temporal parietal or temporal occipital area. This same thing is described in like by Okudera. This is a very nice paper describing the transmedullary vein system. So on the occipital, at the occipital lobe area, you see number 2 here. described as CTC here. It's called transcerebral vein in this article. Usually it's around the temporal occipital area that we see them, like I've shown you in the real case just a while ago. Okay, I'll finish my talk with this kind of strange venous system. So this is a young man with this bleed. What should it be? Usually it's an AVM, usually, because it's a young patient. But in this case, we did like a contrast enhanced CT at the admission, but we didn't see any big vessels inside. Actually, we see less vessels there. Maybe it's because of the compression, but for this case, it's something else, okay? I'll show you this left internal carotid artery injection. This is the arterial phase. A little bit later, there's some mass effect over here. We did already some, I think it was the removal of the hematoma. We tried to look for the cause of the bleeding. We did an angiogram after the surgery. And we see it like a vascular area over here. Maybe it's because of the swelling of the brain still. But we see something right here and some brush-like thing over here. So we weren't really sure what it was. So we did a very long injection because there's some slow, very slow transit of the blood into the venous system. We did a long injection and do a rotational angiography. And what we see, okay, can you guess what it is, Max? Okay, we see something here, but it looks cut
Like a
out
DVA?
like right there. Pardon?
The DVA?
Yeah, so the next thing I'm going to show you is the DVA. So this is the like late phase rotational angiogram of this patient. Okay, so you see there's a DVA, developmental venous anomaly. Like it was like disconnected over here. So these are the caput medusa, and this is the trunk of the DVA itself. So it's draining the deep area, not into the deep venous system, but instead it drains into the superficial venous system. This is one of the transmedullary venous system that has developed into the DVA. So we have a clot here. So it was very unfortunate for this young man that, you know, the DVA is like, it behaves, it functions more like a normal structure. We need the DVA for the patient, but if it gets occluded, it doesn't have a lot of anastomosis with our other venous system. It's like a dead end. So it was a dead end in that territory. So we have a bleed, like a venous bleed. And this is again, so this is the diagnosis was venous thrombosis, developmental venous anomaly. It's not very common to see something like this, but sometimes when you see it, you don't take out the DVA. Actually, it's not the culprit. It's the victim of the thrombosis. So what you do, you give the patient heparin as you would with other venous thrombosis thing. Okay, so this is my last slide, I think. So it behaves like normal. It provides normal function, but it is actually very vulnerable to other, because it's weak in the system, because it's not structured very with you know, backups and stuff. It contains one trunk, draining a lot of area of the brain. Sometimes you see this kind of gliosis on the brain, but actually it's not something very bad that you need to take out. Okay, so that's it. That's a superficial venous system. Thank you. Any questions? Mm-hmm. Yeah,
Sorry, Kiripong, if you go to the Zoom chat, you might see some questions out there.
I'm having problems with when I become
so
the host, I cannot see the chat.
Okay.
I lost the
There was
chat.
a question earlier. There was the question raised that I think you answered about how do you differentiate, say, like a cortical venous thrombosis from a dural fistula. And I guess
It can,
just
yeah,
for like,
it can be difficult. Yeah, it can be difficult sometimes. Well, there are probably many types of, very diffuse fistula. Sometimes we only have one very small fistula draining into one single cortical vein and causing the bleed. It's probably, I don't know, depends on many things. I would go with MRs, contrast enhanced MR, and then look through the TOF images of the MR to see any like feeder-like structures.
sure.
What do you think?
And I
I
think
don't have
of course,
one single answer. Yeah.
The basic answer is, of course, we have to inject all the vessels. So in the first case, of course, you didn't show the external injection, but the,
Yeah.
just the
was
basic answer is
there,
yes,
yeah.
of course, we look at all the injections and we see what's going on. In terms of, I just wanted to add, like, for the group, like, in terms of how you think about this in the big picture, like, when you, as Kitty Pong and I were saying, you want to kind of get into the habit of looking at the brain, at the injection as a whole, and you want to be familiar enough with the system that you can see a piece of the brain being drained by whatever its vein should be. So like you have like a gestalt view of like that every portion of the hemisphere, every, that the volume is adequately drained. If you don't see a vein, if you're injecting something and you don't see a vein on the venous phase of the brain, there's really only two possibilities. And that's really the simple thing about it. If you don't see a vein, there's only two possibilities. Number one is that the vein is closed, right? It's either thrombosed or somehow the vein is closed. And number two is that the vein is not closed. The vein is open, but something else is using it. And that's really gets back to the question of how do you differentiate it? Maybe the vein is open, but maybe it's taken over by some other, basically by a dural shunt, right? Or by some other shunt, but usually it's going to be dural. So those are the only two possibilities that you have to think about. Either it's thrombosed or something's gone taken over the management. And I think there are many ways to answer that question.
Yeah. And I see other questions now. I can see I managed to open the chat window now. Okay, there's one like, do you do DSA in all suspected cortical vein thrombosis? I would say no, and usually it's the contrast enhanced MR that is more important to for the diagnosis. But I would like actually to see some the DSA sometimes to see the collaterals, how it goes, because we don't see those actually on MRs.
There was a question earlier, Kitty Pong, about the protocol for obtaining 3D volumetric images of the veins.
So I'm a neurosurgeon. I'm not very good at the protocols of MRs, but what you do is you have to have like volumetric. It means that it's gapless, thin sliced, T1 enhanced. I think that's it. The other ones you can use the other the T2 to see if there's flow void in the superior sagittal sinus, but that's not really reliable. You can see clots sometimes in the veins appearing on DWI as like high intensity area, but it's not, it's quite specific to the clot, but it's not very sensitive. So it would
what
be
about
contrast
angiographic?
enhanced.
Like say you wanted to get like a rotational angio or some kind of angiographic image of the veins.
I think it takes more experience to interpret if you have a big like superior sagittal sinus thrombosis, I'm sure anybody can pick it up from DSA images. But if you have like right or left transverse sinus thrombosis, you don't really know if it's already actually there at the beginning or it's absent from the beginning. So the DSA takes a lot of experience to see how the veins is a little bit like stagnant around the area. For me, I think so. Any other comments?
There's a question from Rajan. Last case, could there be a cavernoma associated with DVA?
Oh, okay. So there were a couple of questions actually related to the last case of the thrombosed DVA. Could there be like maybe a cavernoma bled? How do we?
Okay, yeah. So it's like they say if you see a bleed, you look for cavernoma, and there can be like 20% of cavernoma coexisting with the DVA. But this one, we see a clot, and we didn't see. Well, there was a big bleed, and you don't see a cavernoma when you have a big bleed around the area. Usually, if we need to be certain if it's a cavernoma, we have to wait until the clot is kind of like disappeared and do it like in the chronic phase of MRI. But this one, it's certain that we have a clot over there, so it's not a cavernoma, and it was not a cavernoma. We have done the follow-up until like 1 year later, and we didn't see anything else like a cavernoma. Yes, but yes, you have to look for cavernoma. It's the thrombosis in the DVA, or sometimes they say there's a shunt with the DVA, but that's really rare. It's not very common to see. We see more cavernomas that usually is the cause of the bleeding.
Right now, yeah. I mean, for those that like for just generally for the audience, as I'm sure you know, like DVAs are do not touch lesions, and 99% of the time, there's no problems with them. But you know, of course, we are interested in the unusual, especially like this. So these are very obviously interesting anatomically cases. And as Kitty Pong was pointing out, the weakness of the DVA often comes from the fact that it has very little collateral potential, right? The DVA is like, there's an unbalance there. So there's a lot of embryology that's interesting in that regard, but it has virtually no collateral. And so the problem is when the DVA does go down, if it's a big DVA, it's going to be a big bleed, you know, or big infarct, venous infarct, and there's going to be like a hemorrhagic thing to it. Okay, any other questions? The other point, I guess the other point for those that are still here, like the other point that I think Kitty Pong and I were making is that, and it relates to how we approach venous sinus thrombosis, because obviously for most of the DVAs, or for most of the venous thrombosis cases, really isolated cortical venous thrombosis is fascinating, and often like it can be hard to diagnose. Most people obviously present with, or at least the kind of like they're worked up as the venous sinus thrombosis, right? So venous sinus thrombosis, the point of understanding, like how we understand venous sinus thrombosis really relates to what happens to the cortical veins. The venous sinus, like there's no problem if you occlude a sigmoid sinus that doesn't have any veins going to it. It's gonna, like the blood's gonna go somewhere else. So you wanna understand like why some people get into more or less trouble with their sinus thrombosis really has to do with what cortical veins are compromised related to that sinus segment. And that's really key. You know, when we open a venous sinus, like, you know, obviously it's a whole other question of how to treat it, but the interventional management of venous sinus thrombosis really has to do with how we allow for the cortical veins to reopen with systemic anticoagulation to then be able to use that sinus again. But the pathology of venous sinus thrombosis is ultimately related to the occlusion of the cortical veins. And to the extent that they're collateralized or not, or what outflow they have or not, really determines what happens, you know, to the brain and what happens to the patient. We could, I don't know if we have time. Should we show another case? How many people we still got here? 217. Okay. Let me see if I can show one case. If I still have it.
I have to give you back the host thing.
Let's see if I have the.
You can take it back from me. Yeah.
All right. Let me see.
Okay. Now, here we go. I think you're back.
Participants. Am I the host now?
Yeah, I think so.
Yeah. Okay. Cool. I can tell. Okay. So let me see if I can Okay. All right. Let me see if I can show my screen. All right. So this is the patient that I didn't show. And as you probably, more and more, I mean, I hope you never see this, but there's just a lot of hypercoagulability that develops with some of these COVID patients. And so more and more, like in the middle of all of this, you're seeing both venous and arterial thrombosis. There are also hemorrhagic cases. There's all kinds of badness going around that not probably infrequently, but still, given the numbers, we see a lot of, relatively speaking, we see a lot more clots, arterial and venous, related to the COVIDs. I mean, this is like a whole other medical part to it. D-dimers are usually followed in patients. I mean, we follow them daily with all these other inflammatory markers, and sometimes the D-dimers are just insane. What to do, it depends. I mean, it depends on how, if the system is overwhelmed, it's difficult to get imaging. So sometimes there's a whole other thing of like, you don't really get too many images on some patients that present with neurologic symptoms. You may or may not be able to obtain images. A lot of the patients that present with overwhelming thrombosis, this is just part of the whole overall decline, and the prognosis is not exactly great. But I wanted to show this case to illustrate kind of the idea of what, like, the relationship between venous sinus thrombosis and cortical vein thrombosis. So this is a COVID patient that presents with a ton of thrombosis. This is a non-contrast head CT. He's a young person, so just a lot of very tight brain. This is the venous phase of his CTA, and we just, like, whatever we do a venous phase, so you can see, you just can see like there's clot everywhere. Now, again, like, how do you analyze this? So you look at this picture, right? So you see like things are really bad on the right, down low here. On the left, look, you see this? So there's a vein. And there's something here. So you can see that probably the Labbe system somehow is still patent. So on the left, things look a little bit better, at least inferiorly. Now here's your internal cerebral system. Here's the Galen. Now here you don't see very much. So this proximal part of the straight sinus is not great. And then as you go up, there's just clot, more clot, right? So here's the angiographic part of this. And again, like, this is more like, I'm just showing this to appreciate what's going on with, like, the relationship between the cortical veins and the sinuses. So here's whatever, right common injection, that's the corresponding picture. So you see the distal straight sinus, the proximal part is a little bit opacified, and of course you don't see any of the other stuff. So this is the right side. You can see the deep Sylvian system that's trying to find its way like an alternative route, and then, some of these other systems are open. There's the back, whatever, there's just a ton of congestion. Now here's the left. So on the left, again, so here's it's not even the Labbe, so this sort of like temporooccipital vein. And there's some of these temporal veins that are still open. Why? Because there is a segment here that's a little bit patent. And then again, like here, you see some outflow into the cavernous system, reversal of flow into the superior ophthalmic vein. Obviously, there's tremendous intracranial hypertension. You see, like, overall how slow this inflow is. So there's, we didn't have a way to measure the intracranial pressure, but when you see it like this, it's not good. So just to fast forward to the end, so at the end, like, let's say you have a picture like this, right? So you have whatever. We've cleaned out what we can. You see the superior sagittal sinus. We inject, and you look at this, right? So what do you see? You see that there's still stagnation here, right? There's a little bit, the flow here is still delayed. Why? Because the cortical veins are active, right? The cortical veins have trouble accessing the segment. Now there's a little bit of, I don't know if you can see the mouse, you can see a little bit of dilution. So you're starting to kind of see like veins accessing the segment. Now, once you get to this point, it's really washing out. And it's washing out because there's inflow from some kind of unapacified source. And that source, you know, we'll see later. So this is like a venous picture, but it tells you that things are pretty decent over here. And there's still not a lot of access to the superior sagittal sinus upstairs. This is the right common injection at the end. Here you go. So now you see whatever, like this is now open. You see some of the back of the more proximal superior sagittal sinus is open. And then you see the sigmoid sinus and then the gut. So anyway, but the point, I mean, the point of what I wanted to show is which catheter, okay, I'll get to that. So just the point that I wanted to show, where is the lateral? Maybe not have, we have the lateral. All right, here you go. That's the lateral on the left side. So again, you already have that, but you're trying to get a little bit more flow back here. The name of the game, though, is to keep the sinus open until these veins recanalize. So these frontal convexity veins have to be able to start draining into the sinus again. Which catheter did we use? We used, so we happen to have a 12 French 80 centimeter shuttle, and that went into, we didn't puncture the jugular because I didn't want to, we wanted to go both sides and I didn't want to compromise that. So we went through the groin with an 80 centimeter 12 French shuttle. And we used the Indigo, the 8 French, the Indigo, the pulmonary embolism system from Penumbra, which is basically like a, kind of like the size of a Neuron Max. And that, so if you want to see that, like that thing got us, so this is like as far as you could put this sort of like, you know, 6 French system here, 6 French, so 8 French, 6 French inner diameter system. And so that's as far as that went. And then we used like the Vecta and the Sophia and whatever. Mostly it was like aspiration thrombectomy. Once in a while we would put up a solitaire to like help drag it out. And it takes, I don't know, we don't, I mean, our philosophy is we typically don't do this. We usually rely, like our philosophy is medical management first, but this is just like one of these extreme cases and it didn't end well. We achieved success, but because of the pulmonary issues, this unfortunately was a bad outcome. We see that with some regularity. By the time they get to be this bad in the head, it's just a reflection of like how bad things are overall. So we try to do what we can. Okay. Any other questions? Let me see. Any more chat? Any other questions? Minimizing blood loss. Well, it was like probably 500 cc's of blood loss. Just try to, you know, whatever, try to minimize it. Most of the time you're in the clot, so you're sucking on clot and there's not a lot of blood coming out, but I'm sure maybe there's a way to like recirculate them or whatever, but at the moment we weren't really into that. Do we use balloon sweeps? We didn't this time, we used the Sali, but we did leave a catheter in the sagittal sinus and we were like dripping some TPA into it by the end of the case just to keep it open. We thought that might help. So Okay, so I want to thank everybody again for coming. Thank you very, very much, everybody, for joining. Really appreciate it. This is our first banana session, and we'll keep going. The plan is there's a lot of information on the webpage and the bananas, like neurangio.org bananas, where you went to the link. We have like an alternating system. Every other week we do this kind of like lecture cases thing. And then every other week, alternating with that, we have like a virtual EMBO club. And so in the EMBO club, it's a free format. You submit a case, you show the case. So we have like, basically, if you want to submit, please try to email us so that we can get you on the roster. It's the email is on the page. It's neurangio@neurangio.org. I think I put that out there. If not, you can use the contact us page, but just the contact us also goes to neurangio.org. Just let us know that you have a case. We have like, try to, there's not too many rules. Just try to keep your case to about 5-10 minutes long to have time for discussion. It's very case based, and we hope to have a lot of discussion going for the cases next week. So that'll be, that's 8, like hopefully 8 to 10 or so Eastern time next week. And I want to publicly just acknowledge that obviously like the planet's round. And so we try our best to pick a time that, there's no time that's great for everybody, and particularly for the West Coast. It's just a time that we have at the moment. Going forward, we'll see what we can do about that, but this is a recorded session. So hopefully the recording will work, I hope. And the recording will be available. We're probably going to put it up on YouTube, and there's going to be a link there, but bear with us for that. Okay. So again, thank you so much. Really appreciate your participation. You're coming in, and we hope to see you next week.